Good morning and welcome back, students. We will continue with competency number 3.2 and today's topic is transport and storage of carbohydrates in body. The monosaccharides are transported in the blood freely. They get filtered into the glomerulus of the kidney and enters into the filtrate. But they are completely reabsorbed by the renal tubules in normal persons. Therefore, there is no glucose is found in the urine in normal persons. The glucose transporters which are responsible for these are glucose transporter 1, 5 and sodium dependent glucose transporter. But when the concentration of blood glucose is very high, then large quantity of glucose enters into the filtrate, which is beyond the capacity of renal tubules to reabsorb. In this situation, the small amount of glucose passes into the urine, which is called as glycosuria, and it is detected by Benedict test. This is mainly seen in case of diabetes mellitus patient when the blood glucose level is high. Sometimes if renal tubules are damaged, then also the capacity of the renal tubules to reabsorb glucose decreases. In this situation also the glucose enters into the urine leading to glycosuria, though the blood glucose level is normal in this case. Through the blood, the monosaccharides are circulated all over the body. They enter into the various body cells with the help of various transporters present in different tissues. These transporters are glucose transporter 1, 2, 3, 4, 6, 7 and sodium dependent glucose transporter. So this is the chart showing various glucose transporters present in different tissues and their properties. Out of these glucose transporters, glucose transporter 4 is important for us because this glucose transporter 4 is dependent on insulin. In case of diabetes mellitus, there is insulin deficiency. Therefore, the activity of this glucose transporter 4 get decreased, and hence these transporters will not transport the glucose from blood to the respective tissues, that is skeletal muscle, adipose tissue and heart. As a result of this, the blood glucose is not utilized and its level increases in the blood, leading to diabetes mellitus. When these monosaccharides enters into the blood, they get converted into glucose by different pathways that we will see later on. Glucose, either it is utilized for energy, or it may be converted into fat, or it may be converted into various amino acids, and the extra amount of glucose which is present inside the cell is converted into glycogen in liver and skeletal muscles. So glycogen is the storage form of carbohydrate in the animals. This is about the transport and storage of glucose. Now we will continue with lactose intolerance and sucrose deficiency disorders. First, about the lactose intolerance. It is due to deficiency of enzyme lactase. This lactase is found only in the intestinal epithelial cells. In lactose intolerance, due to deficiency of this enzyme lactase, lactose is not digested in the intestine, small intestine. Therefore, the undigested lactose reaches the large intestine, where it is acted upon by various bacteria and get fermented into acid and gases. This will lead to loose motions, abdominal pain and flatulence to the patient. There are two types of lactase deficiencies seen. Congenital lactase deficiency, present since birth, and acquired lactase deficiency, in which if a person is not taking milk for a long period of time, then there is no lactase synthesis in the intestinal epithelial cells. Therefore, if a person suddenly take a milk, then he will not able to digest the lactose present in the milk due to deficiency of the enzyme lactase. It is a temporary deficiency. As the patient continues to drink milk, slowly the intestinal epithelial cells starts synthesizing the enzyme, and later on the person will able to digest the milk. So this is about the lactose intolerance. In congenital lactase deficiency, the lactose is not synthesized because the corresponding gene is defective. Whereas in acquired lactase deficiency, there is temporary lactase deficiency is seen. This is about lactose intolerance. Now come to sucrase deficiency disorders. Sucrase enzyme is also found in intestinal epithelial cell, which hydrolyze the sucrose present in our common sugar. As the sucrase is deficient, the sucrose is not digested in the small intestine. As a result, the sucrose is not absorbed because only monosaccharides are absorbed from the intestine. Disaccharides are not absorbed. So the sucrose enters into the large intestine, which is acted upon by the bacteria and get fermented into acids and gases, which may lead to again loose motion, abdominal pain and flatulence. It is a very rare type of disorder. Clinical importance of sucrose. Sucrase is the enzyme which is responsible for hydrolysis of sucrose, and this sucrase is only found in the intestinal epithelial cell. Therefore, sometimes sucrose is given intravenously to the patient to decrease the cerebral edema. This is because when we inject the sucrose intravenously, it is not digested in the blood as the corresponding enzyme is absent in the blood. Therefore, it will remain in the blood for a long period of time until it is filtered by kidney. Due to presence of sucrose in the blood, it increases the osmolarity of the blood. And when the osmolarity of the blood increases, then it will absorb the fluid from the surrounding tissues. So this property is used in treatment of cerebral edema. In cerebral edema, there is accumulation of fluid in the extravascular compartment. So that fluid is entered into the intravascular compartment when the osmolarity of the blood increases. In this way, the cerebral edema is treated by using sucrose solution intravenously. There is a case history related to this topic which is asked in the exam for 5 marks. The case is given like An infant suffering from distension of abdomen, flatulence and watery diarrhea is brought to the OPD by his concerned mother. She told that the child is having such complaint on ingestion of milk. What is the probable diagnosis? The first question is, what is probable diagnosis? As the symptoms are seen after ingestion of milk, the most likely diagnosis in this case is lactose intolerance. So which enzyme is defective or involved? The lactase enzyme is deficient. The third question is, what is the biochemical basis of patient's complaint? As the lactase enzyme is deficient, the lactose from the milk is not digested. This lactose enters into the large intestine, which is acted upon by the bacteria present in the large intestine and get fermented into acid and gases, and this acid and gases will lead to the above complaints like watery diarrhea and abdominal distension and flatulence. How can the complaints can be relieved? As it is a congenital lactose intolerance due to defective gene, the patient will not digest the milk. So in this case, we have to replace the milk by other food. So this is about lactose intolerance and sucrase deficiency. Now we will continue with competency number 3.3. Assimilation of carbohydrate and from food. All of you know, glucose is the ultimate compound which is formed inside the cell from fructose as well as from galactose. Inside the cell, this glucose may be converted into pyruvate by the process of glycolysis. This pyruvate has various fates. It may converted into acetyl-CoA. That acetyl-CoA have different fates. If the excess glucose is present, then that excess glucose is converted into glycogen in liver and skeletal muscle and stored for future use. Some amount of glucose also enters into the HMP shunt pathway. We will see later on that pathway, and get converted into pentose sugars like ribose 5-phosphate, ribulose 5-phosphate, xylose 5-phosphate and xylulose 5-phosphate. These pentose sugars are mainly used for synthesis of nucleotides and nucleic acids. Small amount of glucose also enters into the uronic acid pathway inside the cell and get converted into glucuronic acid. These glucuronic acids are used for synthesis of various types of mucopolysaccharides. This is about the assimilation of carbohydrates. Thank you very much.